Okay, we have two presenters joining us here this morning. Joan Hayden-Roy is the Chief Executive Officer of Elder Services of the Merrimack Valley, Inc. Much of her work at Elder Services has focused on building an infrastructure that supports new initiatives, bringing healthcare providers and accountable care organizations together with the Aging Network for healthcare reform. Jennifer Raymond is the Chief Strategy Officer for Elder Services of the Merrimack Valley and directs the Healthy Living Center of Excellence. She is responsible for strategic planning and sustainability, overseeing a provider network of community-based organizations, as well as efforts to integrate these programs with a variety of healthcare payers. And with that, I would like to turn the presentation over to Joan and Jennifer. Welcome.
Thank you. Good morning and good afternoon, everyone. It's actually 1 o'clock here in snowy Boston. So to start the conversation, I thought we would give an overview of who Elder Services of the Merrimack Valley is, so that we can put the issue of accountability and embracing that culture into context. So we are one of the largest area agency on aging in Massachusetts, and we also have a designation which is called an Aging Service Access Point, which allows us to take in state home and community-based money to authorize services to the consumers within our Merrimack Valley area, which consists of about 23 cities and towns across Massachusetts. We also are going to be celebrating our 45th anniversary this year, and that we've been in business for about 45 years. I've been part of the agency for a large, significant part of that, but in the last 2 years, I became the CEO of the agency, and really we started down this journey of looking at how do we make sure that we're achieving the goals that we need to with some of our all the changes that are happening in the external environment. So when we talk about this title of this conference as being Embracing a Culture of Accountability, isn't to say that haven't been accountable, but it's how do we change the culture in such a way that everybody from our switchboard operators to our admin staff understand what we need to do to continue to grow. So we serve over 25,000 consumers annually. We have about 335 employees and 375 volunteers. We're about a $72 million annual budget, and we do have a couple of designations, including protective services with the Elder Abuse Protective Service designated agency. We are an Aging and Disability Resource Center, and our recent certification designation as a long-term support service community partner, which is primarily serving 11 accountable care organizations through our Medicaid program. We're the statewide network for the evidence-based programs, and that's our Healthy Living Center of Excellence. And in Massachusetts, we are really have been fortunate to have a commitment from the state legislature and the governor to push age-friendly systems, age-friendly health systems, but also we have a designation of being an age-friendly workplace. So that just gives you a little bit of summary of who we are and why we started down this journey. So one of the things that we're really most proud of is that we do have a committed and passionate staff. Our staff is very committed to the work that we do, and that most of the times we're able to really get people excited about some of the changes. But as you know, and most of you probably listening to this call, there's a lot of changing in the external environment, and how do we keep up the pace to be able to keep making sure that we're of value to our consumers. We were one of the first in Massachusetts to get our NCQA accreditation. That's the National Commission on Quality Assurance. I always forget what those initials stand for sometimes. But we did embark on that about 2 years ago, primarily to help to make that shift and that culture change to being able to get that accreditation, and that when we start marketing ourselves to the health payers, that they understand that we've achieved a certain level of quality in the work that we do. We have about 5 managed care programs in Massachusetts. They're called Senior Care Options that serves the duals, and we're one of the largest across the state, and we serve about 6,000 of those through all those duals plans. We have a Medicare provider number for counseling, and we do have a very secure financial future, and our budget of over $72 million helps us to be one of the largest organizations in Massachusetts, but allows us to be able to do some of the things that we might not have been able to do without that security. So the first thing that we wanted to make sure that our staff understood is, what do we mean by accountability and developing a quality strategy? So we looked over what are some of the priorities and the fiscal imperatives of the health systems that we are under. In Massachusetts, we underwent about a transformation over the last few years in that most of our health systems have become part of what an accountable care organization. So as I mentioned earlier, we have contracts with about 11 of those accountable care organizations, each of them having a different set of priorities, each of them having a different IT system, each of them having different documented processes. So you can imagine that in order to keep track that we're meeting all of those goals, it could be quite daunting at times. So we tried to really understand what were the drivers of those organizations. We've had a lot of relationships with the CEOs of those organizations to understand where their pain points are and what some of their challenges were. Understanding things like HEDIS measures, capitation, pay for performance, what kind of financial penalties were they under, not only around avoidable readmissions, but also around not achieving some of the metrics that they were being held accountable. So understanding what they were needing and what kind of challenges they were happening allowed us to be able to align our strategies and our thinking to be able to help them to achieve their goals. So when you look at what our organizations offer, a lot of our products and services do support the healthcare goals. The prevention and wellness programs, the chronic disease programs, overall population health. We're very strong. Our network's very strong in patient activation and education. We certainly play a significant role in reducing unnecessary utilization of health care and avoidable hospitalizations. The issue of improving access to care and making health care attainable for all populations across all cultures is part of our mission. And improving all overall patients' experience and satisfaction, again, something that the healthcare system is really interested in, especially around the issue of competition. And I'm not sure what other people go through with their states, but we're very close to Boston, which has some of the major hospital institutions like Beth Israel and Mass General and some of these big pretty highfalutin hospitals. And so the community hospitals that we're used to dealing with in our immediate area feel the pain often because people will go from their hospital to Boston, and that really hurts the bottom line of the local hospitals. So how do we help with improving overall patient experience and satisfaction? And then finally, we all see ourselves as really being the key leader in addressing the social determinants of health. Most of our organizations have been dealing with these social determinants for many, many years until it got this nice groovy title of social determinants, but the hospitals and the health systems are just starting to realize the impact of social determinants on health. And so the sooner that we step up to the plate and show them that we're at the driver's seat on those two, I think it really puts us in the driver's seat around accountability and quality. So we did some scanning and trying to do a deep dive into our own organization and trying to figure out, do we even need to change? We have some successes. We feel pretty good about what we're doing. We have a long history. So why, if it's not broken, why fix it? So part of that deep dive was doing an environmental scanning. And again, as I took on the job around 2 years ago, it allowed me to really get that face time with the community and with our staff. So we talked about these issues of accountability and quality at all staff meetings. We did interdepartmental SWOT analyses, strengths, weaknesses, opportunities, and threats. We did that as a whole organization, but we also did that within each department. We had listening sessions. I did one-on-one sessions with staff, board, our internal partners. We talked about the role that our middle managers played, and really took advantage of that newness of my position to say, give me some words of wisdom, to really try to understand what was happening from all levels of the community and our organization. And also, as we all know, Tim McNeil is an independent consultant who often gives us really great advice and consultation. So what did we find out? We really found out there was a lot of internal challenges, and that created us to want to drive to what we called restore the core of our infrastructure and restore the core of those services that really got us to where we are now. But if we didn't invest in that infrastructure, and if we didn't invest in really that prime service that we offer, which is care management and addressing the social determinants of health, that we weren't going to be able to go further. So that investment in that core was critical. And some of the things that we realized is certainly we had high caseloads and high turnover, that our salaries, although were sort of competitive to the network, we were losing staff to organizations such as healthcare, where we would train staff and they'd work with us for a year, and then they'd go get almost a double salary going and working into the healthcare system. So we did a lot of a whole salary analysis with the consultants, and we're able to give about a third of our organization of direct service staff, about 150 people, we were able to give close to 4.5% to 7.5% salary adjustment. Staff weren't feeling empowered, that there was so many things going on around them that they didn't feel that they had that drive for their own empowerment. And we found that management sometimes were not accountable to staff, that there was a lot of communication around decisions after decisions were made, not while things were happening, that we had a lot of workarounds instead of solutions, that we put immediate Band-Aids on things. And what that caused is there to be really an overload on the infrastructure of things that really didn't need to happen, but they were just sort of historical why we continue to do them. We struggle with data analytics like many of our organizations. How do we get the data we need to measure outcomes? That many felt we were growing too fast. There were too many things, and there was too much priorities on the new shiny toy or the new things that were happening, and not enough strength and attention paid to the core services. So that was very interesting for us, that we really needed and heard that loud and clear. But we also realized there was many changes on the external environment, what was happening outside of the agency, that we had increased pressures on from our health partners, but our managed care contracts, that they were being held accountable, and that we were also in effect helping them or hurting them in some way, so that we had to make sure that we were helping them with their decreased utilization and trying to improve their outcomes. We saw that there's advantages and there's opportunities happening, such as the changes in the Medicare Advantage, and were we prepared to start addressing that? Our funders were looking for increased accountability for outcomes. We've mentioned many times in other talks that it's not just your traditional, you get a grant and you continue it on for a year and then tell everybody you did a good job. That ongoing, the accountability in our funding relationships, whether they were contracts or philanthropy, we're expecting really good data analytics and very clear outcomes and that we would be held accountable to. Our state unit and our state contracts were increased focus on quality improvement. Again, they were getting push, and that push was coming down to us about new QA measures that we needed to adapt. And then our new contract with the Medicaid ACOs is that we were going to be at full risk in 5 years. And so the ability to take on a 5-year contract knowing that by year 5 we would be at full risk is very scary, but also it created a new opportunity for a good learning environment. So, and then finally, with the NCQA accreditation, it's not that you just get that and it goes away, that you have to be accountable for the next 3 years and making sure you do what you say you're going to do. So what we did from there, I'm going to now turn that over to Jen Raymond, who took us through a process to start transitioning to this new culture.
So good afternoon. Thank you, Joan, and thank you everyone for sticking with us. Jonas talked a fair amount at the beginning of this of how we sort of did these internal looks at ourselves as well as these external scans and environmental looks to see what we needed to change and why we needed to change it so that we could really make the case with our staff and with our leadership that this transition into a culture of accountability was going to be something critically important if we were going to survive. We even did some conversations with our staff where we talked about organizations both in the nonprofit field and in the for-profit field and how they really adapted. They maintained similar missions and visions, but they adapted with the technology and compared them to organizations that didn't adapt with the changes in the environment. So we have a lot of folks running around now saying, whatever we do, we don't want to be the blockbuster of aging and disability in the community. So there was this understanding that these changes were not just because we thought there was something shiny and new that we needed to do, but they were really about sustaining our work, sustaining and advancing our mission, and serving the needs of our clients. But when we first started talking, even with our leadership around transitioning to a culture of greater accountability, there was a lot of concern. There was a lot of concern around that A word. And by transitioning to a culture of accountability, were we making assumptions that we hadn't been accountable in the past? Were we making assumptions or making accusations that our staff didn't care about the work? And even more so, were we now transitioning to an organization that was going to be more responsive to payors like the health system and less responsive to the community members? So we had many of our staff talking about like how we were shifting gears from a social service model into a medical model. We had staff, particularly on the case management level, talk about how accountability would take away some of the art of the work that they do. They were going to be dragged down into data collections and ticking boxes, and it was going to be a pure science of case management and science of delivery of services, and we would have less of an understanding around the importance of the art and the compassion that our clients gave to caregivers. So one of the things we really did want to make sure when we talked about transitioning to a culture of accountability is to make sure we really did understand what accountability meant and who exactly we were accountable to. So not only were we going to be accountable to each other as staff and colleagues, but we had specific things that the board had expectations for us of. There were other community partners, like the folks that we work in independent living and disability, that were having expectations of us. Of course, the state unit and the Department of Public Health, they're always there, as well as our healthcare partners, new partners and old partners, and other funders and payors. But at the very core of who we were accountable to, it was always going to be the consumer and the families surrounding those consumers. So we wanted to make sure when we started using words like accountability that we were putting the right kind of context around those words. The other thing that came up really clear when we started to make these transitions was that we were going to be an organization that was not driven only by the data, but that we had our mission and the direction of the ways in which we would achieve our mission informed by the data, which means we had to transition from where we were in measuring things like the number of people that we serve and other outputs or other activities that we did to put the right structures in place to allow people to look more at the impact of the work that we had and the outcomes that we had. And that wasn't really just diving into very expensive data collection systems. Sometimes it was using stories. So if we knew that there was an individual that we kept out of the hospital for after a fall or something like that, that we weren't stopping with just telling the testimonial, that now we were able to say, and these are the dollars that are saved when that kind of thing happened. These are the outcomes, and this is the impact of those outcomes throughout the year. So we do want to be really, really clear that when we're talking about measuring the success of the work that we're doing, it wasn't just the high-level data things, but it was the day-to-day recognition of the impact that our staff has on individuals throughout the community. We felt like we really needed to have some kind of framework by which we moved this change forward. And the framework that we chose was that framework that's advanced by John Kotter. And many of you have heard or hopefully read some of John Kotter's work. He really is an expert at the Harvard Business School around culture change and has been in that space as an expert for many, many years. You can go out and get any number of his books around culture change, around creating a sense of urgency. The book that we utilized and that we had, I would guess probably now a third of the staff or more has read this book, is a book called Our Iceberg is Melting. And the reason that we chose Our Iceberg is Melting is that it had some strong academic information in it, but it really framed change in a sense of urgency using a fable, using something that folks could read in an hour and really relate to. So I do encourage folks to visit your local bookstore, or if you don't have a local bookstore, check out through Amazon or somewhere else, Our Iceberg is Melting, and it really does create this understanding of how the world around us may change, and we have a couple of different options in response to that. One of them is to do nothing and to expect that we'll be able to survive, and the other is to really adapt to the change, be part of the change as opposed to being subject to the change. So again, I would say a third of our 350 staff members have at least a third have read the book now and come back and come to us with stories of how it has been helpful. The framework for change that John Kotter uses is really starting at the very beginning of creating this sense of urgency. Why is it so important that we change? This is particularly hard when you have organizations like many of you all on the line who have had tremendous success for 10, 20, 40, 50 years, and you have that what's not broken, don't fix mentality. So there was a lot of work doing the things that Joan talked about to get us and our staff to understand that the world was changing. I'll talk a little bit more about creating that sense of urgency. But what you see here really is this continuum for change that we are smack in the middle of. Change is going to take 5 to 10 years, and we're certainly smack in the middle of that right now, where we're still every day working on developing a vision that folks can buy into for change, communicating why that change and that buy-in is essential. And I think probably the most important thing on this list here is empowering our staff at all levels to act. So we'll talk a little bit more about that as we go through. But the first thing that we did after we as an organization decided that we needed to make some changes, that we needed to put greater emphasis and focus on accountability for all of the different partners that we have in the community and beyond, first thing we did was work to stress that urgency and talk to folks about the change that was happening. And we did that through a large number of staff meetings, all staff meetings, individual department staff meetings, where we had internal folks and external folks talk about the work that they were doing and the challenges that they were seeing from folks in the community and otherwise in advancing that work. So we talked a lot about the fact that there were things like these shifts in focus on things like the social determinants of health. And what does this new shift to a focus on social determinants of health mean? Well, it means health systems are going to be either building systems of their own to address things like nutrition and transportation, and or it means they're going to be looking for community partners or other partners to address nutrition issues, transportation issues, housing issues. If we're not changing and being adaptable to that, then someone else will come in and do the work, and they won't be able to do it as well as we do it. So that sense of competition, that sense of urgency was something that we didn't let up on. We created this hashtag across the agency, and it was hashtag We Hear You, so that when we started talking about how the world was changing and how we needed to adapt with it, we had opportunities for folks to come back to us and say, pound sand, I don't agree with what you're saying, or to say, here's one thing that I think we need to be looking at. So for example, this is something that's still happening. Very recently, we started to talk more in our community programs department about Medicare Advantage and the supplemental services or the flex services. And so there was a lot of conversation happening in community programs departments on the Medicare Advantage. And our SHINE director came up and said, I know there's a lot of focus on Medicare Advantage, but I really want to talk about the pros and cons of that plan versus other plans. So it was something that our SHINE director saw a place for her in the discussion, wanted to make sure the voice was heard, and wanted to make sure the process was fully informed. And I don't think that kind of transparency and empowerment would have happened if we hadn't created this movement around urgency and hashtag We Hear You. So there was improved communication across all levels, including our middle managers. Once we got to a place where we felt like enough of the team across the agency was talking about the change and was talking about the urgency around adapting and being more accountable to every partner that we work with, including the consumer and their family members, we wanted to make sure we built this, what Cotter would call a guiding coalition. We built this team of folks across the agency that were going to continue to be the champions. So if we were in a home care staff meeting and someone talked about how all of these new changes were adding to their caseload, that someone on this guiding coalition would feel empowered enough to stand up and say, well, gosh, remember this. Remember how the world is changing, and remember how we have some options or not options to change with it. So that guiding coalition formed what we call the mini strategy teamlet. And the strategy teamlet included our leadership, our staff, and other folks that you see on the board here that were always thinking about different ways in which to continue to stress the urgency to build this coalition and to move forward to address accountability and other quality kinds of issues. One of the things the strategy team came up with in terms of making sure people understood that we were moving forward was coming up with what we used to call easy wins. And then we found out that there actually is no such thing as an easy win. So instead we call them visible successes. So what are the things that are happening around the organization that don't take a ton of change and a ton of work to move forward, but that do take us closer to the kind of organization that we want to be? One of the very first things that the strategy team worked on in conjunction with folks in our HR department and other staff was transitioning from what we call our suggestion box to something that focused more on targeted questions every month. So for example, we would have something as simple as a question box that started to become, instead of offering suggestions, this place where people would maybe offer suggestions or maybe offer a complaint and not a very well-framed complaint. So we did away with a suggestion box and transitioned into more of a question of the month, where we really are asking questions that encourage people to think more broadly about the direction of the organizations and the things that they'd like to see happen in the organization. So those kinds of visible successes that helped engender the trust of the staff to help them see, like, as we are going through these change, our voice is relevant, our voice is critical, our voice is listened to. These, quote, visible successes became quite important for us to continue to focus on. And that is another one of the Kotter steps that we committed to, and that is that we were going to celebrate the small things that happened along the way, so things like these visible successes. Another one of the steps in the Kotter framework that we spent a good deal amount of time and continue to spend some time on is developing this new strategy or this new vision that was going to both honor the work that we had spent 40-plus years doing in the community and was going to adapt to the changing needs of all of the people that we were accountable to down the road. So adapt to the changing needs of clients and their family members, and also adapt to the changing needs of people that were in a position to continue to support and fund the work that we were doing. So after a couple of months process that included staff at all levels, we came up with 3 strategic goals. We could have had 10, but we really focused on 3 strategic goals. And these goals, we feel, do reflect an increased level of accountability. So our first strategic goal was going to honor the work that was already happening. We were going to provide high-quality choices to our consumers and all of the other people that we were accountable to. And what was a little bit different about this goal is that we didn't just stop there. We didn't just stop at saying this is the goal we're going to achieve. We acknowledged right in the goal that one critical factor that needed to happen in order to achieve this high-quality goal was the empowerment of staff. So from the get-go, staff could see in the very first primary goal of the new organizational movement their role, their relevance. We cannot provide high quality to consumers unless you, the staff, are empowered to do the work and you're fully supported. And that means fully supported with technology, fully supported with staff, fully supported with reasonable caseloads, all of those kinds of things. But instead of having a goal that staff would have originally wanted around manageable casework, the goal is really framed around providing the choices and the needs that consumers have. The second goal is more of our futuristic goal, our future thinking goal, and that strategic goal, again, came together through a collaboration of staff, boots on the ground, and all the way up to external partners. And that second goal is to adapt and address the changing needs of our diverse community, including clients, families, community partners. This is really the focus around innovation. So this is the place where we let folks know when we hear about these new Medicare Advantage flexible services or Medicare Advantage supplemental services or other potential contracting with health plans. This is why we're doing it. We're not doing it because it's a shiny new toy. We're not doing it because we want to be medical partners, but we're doing it because the needs of our community are changing. So wouldn't it be great if we could be the HelloFresh, for example, of nutrition services? So we're not talking about a shiny new toy that lets consumers make choice around nutrition, but we are looking at an innovation that's adapting to the needs of the consumers as they change. And then the final goal really was one where we said, it's wonderful to build our infrastructure. It's wonderful to provide choices to consumer. It's wonderful to be innovative. But if we want to do this in 20 years, if we want to be here in 50 years, we have to do it in a way that's financially responsible, that's legally responsible, and that's socially responsible. So one of the things we hear from our staff quite often is how much they really do like that this is an organization that lets them get involved in social activism, lets them get involved in addressing natural disasters that happen either within our country or without. We have a number of our staff who have family members or other relatives in Puerto Rico. So when the crisis in Puerto Rico were happening, this organization took a stand and did fundraising, and staff really did feel like, okay, we're moving to a culture of accountability. That also means that we as staff are going to be empowered to stay socially accountable as we go. So we really did turn accountability from the A word into something that people really started to embrace. Within those 3 goals, we came up with a number of different aligned strategies, again in a collaborative way using information gathered from staff at all levels. So I won't go through all of these, but these aligned strategies made sure that we were looking at reasonable workloads, that we were looking at an infrastructure that was going to allow us to continue to grow. So we weren't going to require folks to use old spreadsheets from 20 years ago, or in some cases pencil and paper, to document that we were going to be investing in IT and data collection and other technologies that were not going to be just another thing that folks had to do, but that were going to provide some assistance in them doing that. We had some goals around addressing the social determinants and some goals around looking at diverse lines of revenue to support the work. So we started to have this shift from our staff and hearing whenever we were going after a new contract or grant, from them originally thinking, oh, this is sort of the organization looking for new opportunities to get money and not support the work that we do. We were able to tie those goals to that first goal of empowering staff, and so folks would see this revenue generation as a way that new staff, new hires, new technology, new infrastructure came in and started to make their work more manageable. We're certainly right in the heart of doing that right now. And again, that culture that looks beyond the 4 walls of the organization when it comes to accountability and compliance, but also looks at fiscal, legal, and social responsibility in a meaningful way. So I'm going to pause there for a moment, and I know we've stopped intentionally with about 20 minutes left for questions. Joan and I are both here, and we are happy to open it up for questions. And Steve, I'll pull you in.
Oh, okay. Are we going to the questions right now?
My apologies. My apologies. There were a couple of slides that I missed, so I need just a few more minutes if that's okay.
That's
Sorry,
totally
Steve.
fine. No, totally
Thank
fine.
you. There are a couple of slides that I missed. So again, I wanted to stress this, for us, this transitioning to a culture of accountability isn't just the right words to say at the right time, but it was also looking at the needs related to data collection, the needs related to IT, the needs related to measuring outputs, outcomes, and impact that were important. So that is something we're still in the process of moving through with folks. Again, communicating and getting that buy-in across all levels of staff. So whether it's through our question of the month, whether it's through our staff meetings, whether it's through departmental meetings, whether it's through the strategy teamlet, whether it's through our staff leadership council, whether it's through external partners, our councils on aging coming in and telling us what they need from us, we're always talking about how important it is to think about all levels of an organization as well as our external partners when we're thinking about buy-in and understanding. I talked a little bit about producing these short-term wins, things that we call visible successes, so that people can say, oh my gosh, there are some positive impacts to all of this change pain that we're undergoing. We invested in some online leadership training for some of our staff who are coming forward and saying, gosh, I want to be more involved. I don't feel like I have the right tools to move this forward. So here's some leadership training that we put folks through, and much of it was online. I talked about the transition of the suggestion box. We are in the middle of, I'm not going to say the middle, we're towards the end of workforce analysis. So when case managers are coming to us and saying, I have too many cases on my deck, we weren't saying, no, you don't, go back. We really did the analysis and said, gosh, you know what, you do. And so how do we address that? How do we change systems? How do we bring in more people in order to address those workforce issues? And one of the other sort of short-term but really valuable pieces that we did, a very easy thing is we looked, I shouldn't say easy, but a very visible thing that we did is we looked at the way that we did our evaluations. We looked at the way that leadership evaluated each other, how staff evaluated their reports, and also how peers evaluated each other. What we were hearing from some people was the process that we had for evaluation was overly cumbersome. There were people that were telling us that it took 4 hours to do one evaluation, if not more time, and that people couldn't really see a connection between their evaluation and their progression at the organization. So we did a really large overhaul of the evaluation process that was focused more on measuring outcomes as opposed to just giving people feedback on how they did. And that was a place that had some really significant enthusiasm and satisfaction. And then, as Joan mentioned, we went through the NCQA accreditation process. We were able to look at how NCQA looks at quality measures, and even though that accreditation is really directed at our home care, the guidance that it provides with respect to how to measure quality can be implemented across all departments. So those are the next sort of steps that we're looking at to make sure that community programs, Healthy Living Center, nutrition, all have that similar focus on quality. I will say this is something that is a struggle each and every day. We feel the pains quite frequently. Every time we have staff who are new to the organization and come in, sort of presenting this challenge around how there is change and movement amongst us, and that we're expecting people not just to do their job, but to pick their head up from occasion and be part of the change, is an ongoing saga. So stay tuned. We're certainly enthusiastic, but also challenged by the work. So there you go, Steve. Sorry about that.
Oh, no problem at all. I'm glad you got a chance to finish up. Okay, everyone, it is time for the Q&A period. So if you want to send in any questions for Joan and Jen, please do so at this time, and we'll get started right now with that, presenters. First question for you: how do you address the accountability with your network members?
So great, thank you. That's a really good question. Through a number of the different work that we do, whether it's the Healthy Living Center, where we have partners that we contract with across the Commonwealth of Massachusetts, or whether it's through our new Accountable Care Organization partnerships, where we partner with other providers or partner with our independent living centers to meet the needs for addressing issues with the Accountable Care organizations. It is this need of explaining and having the other external partners that we really ingratiate ourselves with to understand that we aren't going to be the kind of organization that focuses only on outputs. We aren't going to be the kind of organization that looks at culture. And so it's a lot of the similar work that we do around creating that sense of urgency, sort of talking about who else is out there doing the work, how they could be either competitors or we could turn them into collaborators, and how if we don't continue to evolve and change, someone else will do it and they won't do it as well. So I will give a quick example with respect to the work that we do around reaching people who have arthritis throughout the Commonwealth. The CDC had a really good opportunity, and I think they do it with some frequency, about a year ago, where they were looking for organizations to address public health issues around arthritis. We heard from our State Unit on Aging as well as our Department of Public Health that while they wanted to be really supportive of us moving forward with that grant application, with us being the lead on that there were competitors out there. And one of our biggest competitors here in terms of addressing arthritis and physical activity and movement is the local YMCAs and the statewide alliance of YMCAs. So while traditionally that would have been a competitor, we sat down with the WISE and their state alliance and talked about how the world was changing, talked about how we as an aging network had really good success in reaching a large portion of the population with arthritis, but how there was tremendous value in the WISE being part of a partnership that we could reach people they couldn't and they could reach people that we couldn't. So it was that kind of conversation around being stronger together, how the world is changing, stressing the sense to act now that allowed us to really turn network partners into real partners as opposed to potential competitors.
All right, thank you very much. Next question for you. If you have partnered with state agencies, which agencies and what role do they play as a partner?
Hold one moment. So I'm going to repeat the question and make sure we get this right for folks. It was whether or not we partner with state agencies, and if we do partner with state agencies, what role do the state agencies play? And I'm going to pass it over to Joan to answer that. Thank you.
So yes, I think the state certainly plays a big role in our partnerships, and we're very fortunate in that they're very supportive of a lot of the initiatives we have. So the state actually is, they contract with us for our home and community-based services, our protective services, and a number of other our initiatives. And most of those programs have very clear, defined outcomes and accountability strategies that we have to adhere to. But when there are opportunities across the state that come upon us, and we can turn to them and they look to us to take the lead on them. So, for example, some of the federal grants that come in some states, those federal grants have to go through their state unit on aging. And in a lot of circumstances, the state allows us, especially the Healthy Living Center, to be the actual applicant. So certainly pulling in your state units and showing them what you're able to do and having them as a core part of all of your initiatives, I think is a critical move.
Okay, great, thank you. Next question for you. What online leadership trainings did you use?
So we're fortunate enough here in Massachusetts to be really good partners with Boston University. And Boston University has a division within the university called the Cater Institute. And the Cater Institute really does have a focus on online trainings directed at folks who are working in aging and working in social services. So there are one-off programs, meaning one course, around case management. There are full curriculums, certification courses around case management, around leadership and supervision, around any of the variety of things that we want to work on. They're also working on one now around accreditation and accountability itself. So the Boston University Cater, C-A-D-E-R.
Jen, just a couple minutes ago you were talking about manageable workloads for the employees. How were you able to measure that?
So I'm going to pass it over to Joan. She's really good at this one.
Maybe. So we're in full transparency. We're still doing a lot of work around case efficiencies and caseload sizes. As I may have mentioned earlier, when we were doing the deep dive, what we found is that there's been a sort of a urban legends that have gone on for many years around why something has to be done. So, for example, a care manager, with a caseload of about 85, may have been following 2 or 3 procedures that, when we looked at it, really didn't need to happen. And we had to go back and say, why are we doing these things? So we were able to create a lot of efficiencies by cleaning up our act, making things simpler, really looking back at the regulations and trying to really streamline what we do. Part of one of our issues is that because many years we just put Band-Aids and Band-Aids and Band-Aids on it, those Band-Aids were actually costing money. So for example, if we took all of these Band-Aids, like for example, we live in very urban Greater Lawrence, Greater Haverhill, Greater Lowell, which has a very low-income, high urban population, and doing Medicaid applications is a real critical part of what our case managers have to do. So we took that task and actually created positions where we'd have somebody do that to assist the care managers. Well, what that does is that also takes away some of the FTE positions that we can allot to care managers. So it's not to say that each of those positions aren't fully utilized and needed, but we really are doing that streamlining to see how do we simplify the job and try to make things more manageable. And then at that point, we've been able to do a workload analysis of our entire department, and it did seem that we were about 5 to 6 staff positions short. So now what we've been able to do, because of our high turnover, and that turnover creates a lot of impact on caseloads, because, you know, obviously it takes a while to get somebody up and trained, we've been able to, in 3 of our departments, we hire people in advance knowing that we've done some data analysis on how often we have vacant positions. So we have people what we call on deck. So we'll always have 2 to 3 staff in waiting, being trained, getting ready to do the job, anticipating that next vacancy. And not all vacancies leave. We have a lot of internal movements where people go to other positions. But what that's done is that's helped with that workload analysis. So that's been an activity that's been undergoing probably close to a year now, where we're finally being able to see some results of what we can do to help make that workload more manageable.
All right, thank you very much. The next question for you here, are you willing to share your employee evaluation tools?
So that's a really good question. I'm looking at Joan, and I think we have to double check with our HR person, but she's sitting here shaking her head saying, yeah, I don't think that there's a problem with that.
Yeah, I wouldn't say though that ours. I mean, I don't think they're the stellar evals that we certainly need to do some more work on how we do our evaluations. So I guess what I'm saying in full transparency is that I don't think it'll be a problem sharing it, and I will check with our HR department, but I'm not sure they're the best tools available. But certainly I'll get back to you, Steve, on that.
All right, very good. Next question here. What measures are being taken or have been taken to build an evaluation to give a true measure of your accountability goal achievements? And second part of that question, has funding made any of this process difficult?
Well, funding makes everything difficult, doesn't it, or the lack thereof. So when I think about the measures that have been taken to see, gosh, is this accountability working? Are we moving in the direction that we want to be moving? I put those into 2 different categories. The first category is around, are we really being successful in engaging and empowering staff? Are we getting staff to the place where they understand this new direction and they still feel committed? They still want to do the job in the best way possible. So we are currently participated and invested some meaningful resources in an engagement and empowerment engagement survey of our staff using the Gallup organization. So that I was really excited to hear. I think it was in the first 2 days we had about close to 30% of the staff who had already replied. Now, does that mean they replied because they're really eager to talk about how much they dislike this change, or are they replying because they're engaged? They understand that their voice informs the process. So hopefully in the next month we'll have some real outcomes that allow us to measure that level of engagement, empowerment that staff feels even after these last 2 years really of change. And then the other piece is that I'll talk, for example, on the work that we do on our federal grants or our applications for federal grants. When we're applying for funding now, we aren't just looking at how we're going to measure outcomes, how we're going to measure numbers and outputs, but we're building in strategies that allow us to measure whether or not the work makes a difference. So, for example, in our arthritis grant, one of the things that we're going to be measuring are things related to population health. Are more people in Massachusetts participating in physical activity or walking programs because of the work that we're doing? In terms of one of the new contracts that we have with a housing site to do services and to have a nurse in there, one of the things that they have built into this accountability, this measurement tool, are things like reduced hospitalizations, reduced emergency room visits. Does having our case manager and having our nurse on staff there during the week, does that impact the number of unnecessary hospitalizations that are out there? So we're certainly seeing in many different pockets of how the transition is already happening. And I think Joan is going to add a bit more to that.
Yes, and also to say, you know, one of the interesting outcomes of us starting to do this accountability and quality deep dive, so in our current evaluations for our care managers, we do have quality measures that go into each of their evaluations, and they're based on some of the state contracts. So, for example, do you get out to your visits within the 3-day window? How often do you get your paperwork in on time? So there's about 3 or 4 measures that go into somebody's evaluation. What was interesting is that we were collecting that information and we would evaluate an individual on that, but we never looked at it in the aggregate. And then even if we did look at it in the aggregate, we weren't looking at trends and we didn't do anything with that information. So if we had 90% of our staff not being able to get out on visits on time, well, that said something about, don't we need to adapt or do something to address that? And for years, we were just collecting that data and doing nothing with it. When we did this sort of movement toward this, a culture of accountability, we started looking at those trends and then addressing that. So that's just one more way.
All right, very good. Next question is kind of a multi-part one, and I will repeat any part of it that you need me to. The question is, who or what was the impetus to institute these changes? How did you get started? And once started, what was the mix between internal drivers and external resources like consultants to help guide the process?
Boy, that's a great question and a fully loaded question. And I'm glad that you mentioned the mix between the internal work and the external partners and resources and competitors, because it certainly was a mix of those things. And I may be a bit biased here, but I will certainly share that, many years ago, 10 years ago or so, more than 10 years ago, we started talking more with some of the local clinicians, some of the physicians who are working in the community, some of the hospital systems that were working in the community, and we started to learn a little bit then about the role of patient activation and patient empowerment. So working with folks in the external world in that way brought us to look at things like the evidence-based programs, and the evidence-based programs really became one of those areas, one of many, but one of those areas where we could in a meaningful way say, gosh, it's really important that health systems partner with those of us in the community who are delivering social services, not just case management, not just care transitions, but the delivery of services so that we had the greater ability. So it was folks like our Dr. Rob Schreibers. It was folks at the Tufts Health Plan Foundation. It was a partnership, a grant that we got from John A. Hartford Foundation that really did help us to understand that there needed to be some integration between health and social services in order to move forward in a meaningful way in impacting health. And because we had some significant leadership buy-in by folks like Joan here and her predecessor, who could see that, gosh, even if we can't see the real ROI today, even if we can't see the connection, we can see that this is a direction that's moving forward. So I think it's really important when we start trying to understand why change is important, that we listen to folks, again, like the folks at the Business Institute here sponsoring this webinar, that folks at M4A and ACL and NCOA who have their eye on the national picture, but that we're also holding hands very closely with the people in our local communities so that even if these big picture movements are moving forward, we can find ways to start with them in smaller ways at a community level.
Okay, well, it's time for us to wrap up today's webinar. We've reached the end of our hour, unfortunately. But Joan and Jen, I want to thank you for being here with us today and for a great presentation. Thank you.
You're very welcome.